Good day, everyone, and welcome to today's Meeting the Needs of the BBC Members with Pulmonary Fibrosis program. Please note today's call may be recorded. I will be standing by if you need any assistance. It is now my pleasure to turn the conference over to Ms. Barbara Kaplan.
Thank you so much, Chris, and hello, everyone. Greetings and welcome to the June 2017 Better Breather Club Facilitator Support Webinar on meeting the needs of Better Breather Club members with pulmonary fibrosis or idiopathic pulmonary fibrosis. My name is Barbara Kaplan, and I'm the National Director for Lung Health Education. I'll be your host for today's learning opportunity. Today's webinar marks the second of our 4 events that we have planned for 2017. So be on the lookout for additional information regarding upcoming webinars that we have scheduled. These will be posted in our BBC Facilitator e-newsletter. I'd like to recognize the sponsors for today's webinar. Today's educational program is made possible with support from Boehringer Ingelheim and Genentech, so thank you so much. This webinar is being recorded. Participants have been placed in a listen-only mode. A recording of the webinar is going to be added to our Better Breather Club Facilitator support page on lung.org. We hope that the information that you learned today will inspire you to open your clubs to pulmonary fibrosis patients, or maybe even to start a new club to help meet the needs of pulmonary fibrosis patients in your community. We have enabled a few webinar features for today's call to make it a very engaging experience. So be on the lookout for a few polling questions so we can learn about you and what you know about pulmonary fibrosis. You will also have the opportunity to engage in the conversation through our discussion pods feature. I'll provide instructions when we get to that part of the learning opportunity so you can participate. And after the presentation from our expert speakers, we'll be responding to questions from you. You can enter your questions into the queue at any time during the presentation by entering your question into the Q&A box. Simply enter your question and click Submit. All right, so let's get started with our very first poll. We'd like to learn a little bit about you. So please select a statement that best describes you. Are you I'm a patient trained to lead a Better Breather Club. I'm a licensed healthcare practitioner. I'm a community health educator. I'm an American Lung Association staff person, or perhaps none of the above. Great. So it looks like the majority of our participants on today's call are licensed healthcare practitioners that are trained to lead a Better Breather Club. We'd like to welcome you and all of our fellow listeners today. We have another poll. We're very curious about what portion of your Better Breather Club members have a diagnosis of pulmonary fibrosis or idiopathic pulmonary fibrosis. So tell us a little bit about your club. Would you say none of the members, some of the members, most, all, or maybe you don't lead a club? All right, so it's looking like, a few more coming in. There we go. So it's looking about like there's about 73% of our callers today who have some patients living with pulmonary fibrosis. So this is great. We're hoping that on today's call that you will gain a better understanding of pulmonary fibrosis and the treatment options available. Understand the needs of patients and caregivers living with pulmonary fibrosis. Being able to recruit pulmonary fibrosis patients and caregivers into your Better Breather Clubs, and the ability to access some of the resources that we will make available to help you better meet the needs of those patients. Without further ado, it gives me great pleasure to welcome our expert presenters today, Dr. Catherine Black and Ms. Karen Smoot. Dr. Black is a pulmonologist at Massachusetts General Hospital in Boston, Massachusetts. She received her medical degree from Harvard Medical School. Dr. Black specializes in pulmonary disease with a focus on pulmonary fibrosis and other interstitial lung diseases. She's working on several grant projects to unlock the mysteries of all sorts of pulmonary fibrosis. She has published numerous articles on the basic science behind pulmonary fibrosis, and she is the recipient of an American Lung Association grant award for her project titled Mechanisms of Fibroblast Activation by Epithelial Injury in Lung Fibrosis. So Dr. Black, I hope you can say that title better than I did. I'd also like to introduce Karen Smoot. She is a patient living with pulmonary fibrosis, and she's a pulmonary fibrosis support group leader in Albuquerque, New Mexico. She was born in Pittsburgh, Pennsylvania, and she's lived in New Mexico since 1984. Ms. Smoot has worked in the healthcare industry for over 30 years. She served as the Divisional Vice President of Network Management for Blue Cross Blue Shield of New Mexico for 17 years. Karen retired from Blue Cross Blue Shield in 2015. She was first diagnosed with IPF in 2011. She became involved with a local IPF support group in 2013 after contacting Loveless Respiratory Research for information about the disease. She attended several meetings over the next few years of the support group, and upon her retirement from Blue Cross Blue Shield, she offered to facilitate a group since it appeared that there were no longer the resources to help support the meetings. She has been able to use her knowledge of the healthcare providers and the managed care system to assist members in her support group. Beginning in July, Ms. Smoot will assume the role of chair of the board of the American Lung Association in New Mexico. So I'm very pleased to have both of these ladies join me today to talk about this topic. And to get us started, to give us an introduction to pulmonary fibrosis, I'm going to turn the presentation over to Dr. Black.
Thank you very much. I'm very excited to be here to talk about pulmonary fibrosis. First, my disclosures. I don't have any financial disclosures, and I always want to mention that I might mention use of medications that is off-label. So to get us started, I thought I'd ask some questions about pulmonary fibrosis, beginning with what you think are the causes of pulmonary fibrosis. So I have a couple options here: smoking, genes, your environmental exposures, whole body diseases, none of these, all of these, or you can always just not vote. But there's not going to be any punishment for knowing this. I just want to get a sense of what you guys have been thinking about. And then by the end of the talk, hopefully you'll all have at least the same answers that I do. All right, so I think it looks like most people are leaning towards the all of these, which is a pretty safe answer here, but I'll go over some of the reasons why all of these do contribute to pulmonary fibrosis. So next, just a quick question about possible treatments for pulmonary fibrosis. So can you treat it with inhalers? Do you use prednisone? Do you use pirfenidone, nintedanib, Nintendo? None of these or all of these? I'm just curious how many people have worked with patients who've been on some of these medications. Nice. So it looks like I'm seeing that most people have picked pirfenidone, which is one of the new antifibrotic medications. Looks like no one's on nintedanib, which is actually another one. And Nintendo I just put on because it's the only way I can remember how to pronounce nintedanib. But we'll go over some of these other treatments at the end. Next, true or false, do you think pulmonary fibrosis is very similar to COPD? Okay. And then, so everyone thinks no, that is totally false. And then the next question, do you think pulmonary fibrosis is very different from COPD? So I'm guessing here that most people are going to think that's true. I put this question up because I actually think that there are some ways in which it's very similar and a lot of ways in which it's very different. And I hope to cover many of those different reasons in the next few minutes. So to give more of an introduction, so what is pulmonary fibrosis? That's just a general term for scarring in the lung. Fibrosis means forming scar, and pulmonary obviously means having to do with the lungs. So pulmonary fibrosis is not a specific diagnosis. It's a general term for a subset of what is known as interstitial lung diseases. Sometimes you'll see the abbreviation ILD. And to be precise, idiopathic pulmonary fibrosis is a specific diagnosis. That is one kind of pulmonary fibrosis. We sometimes use the term interchangeably, but idiopathic pulmonary fibrosis, or IPF, is a specific diagnosis. Pulmonary fibrosis is just a general term. So to explain what that means, this is a diagram from the NIH website showing what the normal lung looks like. And you can see the branches of the airways starting with the trachea in the middle, out to the main airways, and then continued branching until you get to the small air sacs. And where the blue arrows are is what's called the interstitium, which is just the space that's around the air sacs and the small airways. And usually that's an extraordinarily thin layer, just about the width of one red blood cell. You can't see it on a CAT scan. It's extremely thin, and that lets oxygen go straight from the air sac into the bloodstream. But in pulmonary fibrosis, you get a buildup of fibrotic tissue around those air sacs and around the very small airways. And that makes the lungs smaller and stiffer, and it makes it very difficult for oxygen to go from the air sacs into the bloodstream because that space gets slowly destroyed. So how common is pulmonary fibrosis? This turns out to be a harder question to answer than it should be because it depends a lot on when people ask the question, what population they looked at, how specifically they defined pulmonary fibrosis. So specifically, idiopathic pulmonary fibrosis was sort of invented not that long ago, in the sort of 20, 30 years ago. So our estimates of the diagnosis have changed as our definition has changed, and it depends how you get your diagnosis. If you use billing data, you get very different numbers than if you use pathology data, for example. But the estimates from recent papers suggest that it's around, say, 9 to 40 per 100,000, which is sort of comparable to new diagnoses of lung cancer, so it's not that uncommon. And the prevalence, which means the number of people who are living with the disease at any given time in the United States, is thought to be anywhere from 14 to 500 per 100,000. One website suggests that there are about 50,000 new cases a year and about 40,000 deaths per year. So that's about a third the number of new cases of lung cancer in the United States, for example. So how do we diagnose pulmonary fibrosis? Usually people come to this diagnosis with a combination of their breathing tests, so what we call pulmonary function tests, or PFTs, and really the radiology, which gives the most precise definition. So just to go over how we use pulmonary function tests, because I'm sure many of you are familiar with seeing these results for the patients you spend time with. So the FEV1 is the forced expiratory volume in 1 second. That just means how much, when you take a deep breath in, how much air comes out in the first second. The FVC is the forced vital capacity. That's the total amount of air that you can breathe out when you've taken in as much air as you can. The total lung capacity is how much air fits in your lung when you take a deep breath. So when you exhale fully, there's still a little bit of air left, and so the total lung capacity includes that amount. And then we can measure what's called the diffusing capacity, which is a way to try and measure how much oxygen can go through the lungs into the blood when you take a deep breath. And so differences in these PFTs help us as lung doctors distinguish pulmonary fibrosis from COPD. So as I mentioned before, pulmonary fibrosis makes the lungs small and stiff. So the FEV1 goes down and the FVC goes down because you get less air. You take smaller breaths, so when you breathe out less air in the first second, and you breathe out less air overall. The total lung capacity goes down because your lungs are smaller, and the diffusing capacity goes down. COPD, in contrast, is a problem where the lungs are big and floppy, so it's hard to empty them fully. So you still exhale less breath in that first second, but overall, the amount of air that you can exhale is higher than normal. Your total lung capacity is higher because, again, you get lungs that are bigger and can hold more air, but the diffusing capacity goes down because that extra volume is because there are, I think of this, there are holes in the lung, And so even though the lungs are holding more air, there's not more effective absorption of oxygen. Then we look at the radiology. So x-rays, or really CT scans, I think are the reason that we appreciate this disease so much more in recent years, can show what this thickened interstitium looks like. So I just gave one example here. So this is a CT scan of a patient with pulmonary fibrosis, and you can see at the top of the lung, you can see some lines and dots which represent the normal airways and blood vessels. But if you look at the bottom, particularly the bottom corner of the lung, you can see these thickened holes. We call that honeycombing because it looks like stacks of honeycomb, and that shows, again, the thickening of the fibrotic tissue around the air sacs. So this would be a classic CT scan for someone with actually idiopathic pulmonary fibrosis. So what causes pulmonary fibrosis? Well, there are a number of different things that can cause this process. So whole body diseases can do it. Patients with rheumatoid arthritis, with scleroderma, with something called sarcoidosis, with other autoimmune diseases can have pulmonary fibrosis as a part of their whole disease. There are environmental exposures that can cause this. So we've probably all heard of people getting lung disease from exposure to asbestos. That can cause pulmonary fibrosis. There's something called hypersensitivity pneumonitis, which means inflammation in the lungs because of something you're sensitive to. So people who have reactions to bird feathers or to certain molds can get a lot of inflammation in the lungs that eventually turns to scar, and they can end up with pulmonary fibrosis. And then for a lot of patients, there's no clear reason why they develop the disease, and that can be this idiopathic pulmonary fibrosis. So what are the risk factors that make it more likely that you might get pulmonary fibrosis? So smoking seems to increase the risk, but it's definitely not a disease seen only in smokers. Your genes probably play a role. People who study this think that up to about 10% of what we think is idiopathic pulmonary fibrosis might actually be related to a family disease. But we don't have a clinically useful genetic test. It's not like we can test people and say, oh, you're going to get pulmonary fibrosis, or even we should give you this treatment because you have this kind of pulmonary fibrosis. So for now, the genetic component is really useful mostly for research. And then age is probably the biggest risk factor. I've often said that I think if we all lived long enough, we'd all get pulmonary fibrosis eventually. And what you see in studies is that it's unusual to see, especially idiopathic pulmonary fibrosis, in anyone under age 50, and it becomes much more common as patients age. What are the symptoms of pulmonary fibrosis? The big one is shortness of breath. You get scarring, which blocks gas exchange, so you also see oxygen levels that fall quite quickly during exercise. Often people will have a normal oxygen level when they're resting, but as their heart rate goes up and blood has to move faster through the lungs, there's less time to absorb the oxygen, and so somebody who has a normal oxygen level at rest may have quite low oxygen levels just when they start to walk. Patients with pulmonary fibrosis can develop what's called pulmonary hypertension because the scarring can also destroy the blood vessels in the lungs. This puts a strain on the heart, and that can be another reason to be short of breath as the heart starts having more difficulty moving blood through the body. Some patients develop a really bothersome cough. It's usually a dry cough as opposed to a really mucously junky cough that you see in COPD, but the cough can be very annoying, and we don't have great treatments for it. And then fatigue. The pulmonary fibrosis itself probably makes it harder to breathe when you're asleep, so people seem to be more likely to get what's called sleep apnea. And in addition, just having a low oxygen level can make you more tired. So fatigue, cough, shortness of breath are some of the main symptoms that we see. How is pulmonary fibrosis treated? So if it's the idiopathic kind, if you can demonstrate that there's no other whole body disease that's causing it, then there are currently 2 medications that are approved for this, and it sounds like you guys are all familiar with pirfenidone. There's another medication called nintedanib, which is also approved for treatment of pulmonary fibrosis. And it's important that in the last few years, studies suggest that anti-inflammatory medications like prednisone or something called azathioprine, in a big clinical trial of idiopathic pulmonary fibrosis, those anti-inflammatory medications look like they made people worse. So for us as physicians, it's really important to figure out if someone has idiopathic pulmonary fibrosis or if they have some underlying inflammatory disease like rheumatoid arthritis, like scleroderma, because in that case, the anti-inflammatory medications may be quite helpful. And medications that we will use sometimes are prednisone, mycophenolate, mofetil, or azathioprine. You may have heard of them as Cellcept or Imiram. So deciding what kind of pulmonary fibrosis it is very important for those of us that are pulmonologists, although for the patients, the symptoms and the way they feel may be very similar. And I just mentioned here that inhalers in general don't help patients with pulmonary fibrosis, since the problem isn't that the airways are tightening. The typical inhalers like albuterol, which open up the airways, don't really make a difference. Although sometimes people are unlucky enough to have a little bit of asthma and pulmonary fibrosis, and for those patients, the inhalers can help, particularly with the cough. I wanted to just add that the current medications only stabilize idiopathic pulmonary fibrosis. Currently, the only real cure is a lung transplant. So that means people need to learn how to live well with their pulmonary fibrosis. Pulmonary rehab is really a central part of management because it helps people maintain their exercise ability, allows people to stay fit so they can do more even though they're not able to bring more oxygen in through their lungs. So what is the expected course? Well, some forms of pulmonary fibrosis are treatable. If you have an inflammatory disease, anti-inflammatory medications can help. If the problem is exposure, then if you remove the exposure, the disease can get better. But a lot of the forms of disease just slowly get worse. The course is completely unpredictable currently. Some people get slowly worse over decades. Some people get worse very quickly. But every patient that I've met has come across the statistic that the median survival time for idiopathic pulmonary fibrosis is about 3 to 5 years. What that means to any given person is probably not much, but I do think it's important to remember that most of our patients have read that, and so at least when they come to my clinic, they are already quite frightened. So I had said that I think in some ways pulmonary fibrosis is quite similar to COPD. So it's a chronic disease that's sort of incurable. Once you have it, you can't make it go away. It leads to some of the same problems that you have to think about conserving energy so you don't get so short of breath you can't live your life. As it progresses, you're probably going to need supplemental oxygen. And similar to COPD, with pulmonary fibrosis, there are times when people suddenly get a lot worse, sometimes have to go to the hospital, require different medications, and hopefully recover, but often need more oxygen or are more short of breath than they were before the exacerbation. And as with COPD, patients with pulmonary fibrosis might need to be thinking about whether a lung transplant would be a good option for them. Now, there are also some big differences, and I think one of the big ones is that the general public mostly hasn't heard of pulmonary fibrosis. So many of the patients that I've talked to feel kind of isolated because they can't really explain to people what they have, or they have to do a lot of explanations. Whereas with COPD or emphysema, most people have heard of it or know somebody who has it. Unfortunately, pulmonary fibrosis often gets worse faster than COPD does. So people have to face that their oxygen needs and lifestyle may be changing more quickly than someone with more stable COPD. And they also need a lot more oxygen to do their daily activities. Not everybody, but I do find that you need to think about really trying to meet increasing oxygen needs in many of these patients. The treatments, as I mentioned, are different. So most patients with pulmonary fibrosis won't be on things like prednisone. And then the way to think about controlling your breathing during exercise is different. So just to highlight that, with COPD, the problem is really that it's hard to get breath out. And so if you breathe quickly, your lungs become what we call hyperinflated. They get fuller and fuller until they're so full you can't take any more breaths. And so you need to take slow, deep breaths and really take your time to exhale. And sometimes people use pursed lips to try to keep their lungs open and help the air come out. And pulmonary fibrosis is the opposite problem. It's hard to open the lungs and breathe in. And so you need to take slow, deep breaths to fill your lungs, but you really don't have to worry about hyperinflation. So in conclusion, pulmonary fibrosis is just a general term for a disease process that causes scarring in the lungs. It can be caused by whole body diseases, by genetic factors, by environmental exposures, or have no clear cause. The treatment could be prednisone, immunosuppressant drugs, or it could be one of the new antifibrotics, such as pirfenidone and nintedanib. And we clearly need to find a cure for this process because lung transplant is certainly not a good enough solution. I just put some sources for more information here. Obviously, the American Lung Association has a lot of information. There's something called the Pulmonary Fibrosis Foundation. And then one of the interstitial lung disease specialist in Columbia has a blog that's really meant for patients and caregivers about pulmonary fibrosis, which I found really helpful for addressing a lot of the questions that come up. And then I'm obviously happy to take any questions at any time.
Wonderful. Thank you so much, Dr. Black. This was a wonderful introduction to pulmonary fibrosis. I think, our Better Breather Clubs are support groups for people living with chronic lung disease. And this was a request from our Better Breather Club facilitators. I think they're getting more and more interest from pulmonary fibrosis patients to join their clubs. And I think one of the questions on the table was really how to include pulmonary fibrosis, if pulmonary fibrosis patients need a club of their own, or can they join in with other patients. So it sounds like there are some, definite differences, but there might be some similarities among both patient groups that they might benefit from some topics, learning some topics together. I'd like to transition now, and actually before I do that, if Dr. Black has stimulated some questions for you, you can go ahead and drop those into the Q&A box at any time, and we'll continue with the discussion. We'll do a Q&A towards the last 15 minutes of the call. But I do want to move now to our next speaker, Dr. Karen Smoot, who is a patient and pulmonary fibrosis support group leader in New Mexico, to talk a little more about meeting the needs of patients with pulmonary fibrosis and idiopathic pulmonary fibrosis. And again, our goal here really is to help our Better Breather Club facilitators understand and understand the needs of patients living with disease. So, Karen, I'd love if you could tell us a little bit about your experience as a patient, and what were some of your feelings when you were first diagnosed?
Okay. I was diagnosed in 2011, and I had contacted at that time Loveless Respiratory Research just to see if they could provide some additional information about the disease, because in 2011, although they've enhanced what is available information on the websites, it was somewhat limited and very general. So at that time, they were conducting a seminar on, and they had individuals from, actually, I think from Boston, that did the presentation. At that time, I realized that support groups, the importance of support groups, it was very significant because of just being able to talk to other people that had the same disease. Because as Dr. Black mentioned, that there are many people that feel that there's lots of other information out there, regardless whether or not it's lung cancer or COPD, but very little information about IPF. And if those individuals had looked at anything on the website, all they found was really bad news. And they thought, well, it's not curable, and they're going to die within 3 to 5 years. So I found that in getting involved in these, in the support groups, that sharing information, because the individuals in the groups that I've been running for the last couple of years, they are at so many different stages. Some come in on oxygen. They're on oxygen 24/7. Myself, I'm only on oxygen at night. I'm not on oxygen 24/7, and I have a couple guys in the group that have had lung transplants. So it was very clear that the differences that people were experiencing in terms of stages of their disease, it was really important to share with other individuals in the group, people that actually had it.
Great. So what would you say some of the biggest challenges or barriers are that a pulmonary fibrosis patient might face?
I would say that they don't know where to go. They feel that the medication, and until the new drugs that are specific to IPF came out in the last few years, they really felt that their physicians may or may not be kind of stabbing in the dark as to what medications may help them. And so they were so unsure as to is this medication that I'm taking going to make me live longer? So they really had so little information about it, and they really felt that there was nothing more to be done. And the other thing, I think, on an emotional basis, because as also Dr. Black pointed out, that in terms of this disease state, people tend to be older. And I have several people in the group that have been married like 50, 55 years, and they really feel that it's hopeless. They see their spouse and their partner, that there's nothing that they can do for them. And so I think that that is certainly some of the challenge, that they wonder whether or not there's any hope for them to lead any kind of quality of life, even if they are resigned to the fact that they may have a shorter lifespan. Even if they're resigned to that fact, they just don't know what to expect.
Mm-hmm. Great. So would you have any tips for some of our Better Breather Club facilitators on helping to meet the needs of patients and caregivers living with pulmonary fibrosis?
I would say in terms of trying to get people involved in the support group, because I find that I think there was a question that was brought up about whether or not caregivers should be involved in the IPF support group, and I certainly believe that they should, because sometimes I find out that especially men that have been diagnosed, they may have a different viewpoint of what a support group is, and they resist coming. So oftentimes I find that they don't come, but their wives do, or their caregiver comes. And so I think it's really important to try to engage those individuals. And once you do, then usually you find if the men or someone who has been resistant to participate in the support group finds that it's of value to them, then it increases the participation.
Terrific. Is there anything else you'd like to share about being a support group leader, and what is it that you would want another support group leader to know about you in order to make a real meaningful support group experience?
Okay. I would say that, the method that we use here is because we've always been associated with Loveless Respiratory Research. They maintain a mailing list of those that they have had perhaps on clinical trials or people that have just inquired as to what research is being done on IPF. So I work very closely with them, but they also they provide information and a referral source, because I find that some of these individuals need a lot of reminders. So I send out flyers once a month. We have a meeting once a month, and it's on the same day. That's another important thing. Same day, same day of the week, and the same time each time, because they tend to forget. But if they put that on their calendar, they're more likely to remember. We also, the American Lung Association, because they're so supportive of what we're doing, they also send email reminders to individuals to remind them of the meeting, and those that we have email addresses for. And then I call a lot of them, because it's not just that they've forgotten. They are, there could be something else going on in their life. And so I really try to, if they feel that they can't attend a meeting, we have a conference line that is set up. So I really try to encourage them to come in a variety of ways, because once they come, they really do find the support group very, very useful to them. And I think it also depends on the topics that are presented as to whether or not that, how valuable they feel those topics are. And of all of the ones that all of you who run these support groups probably have already thought about and had presenters that do these topics, do topics such as reading PFTs and pulmonary rehab, and traveling with oxygen, and some information on clinical trials and lung transplants and insurance. But one of the best the meeting that we had the most participation and the most enthusiastic comments afterwards was teaching breathing. And I really can't tell you how people loved those sessions. I have a friend who has been teaching breathing for 30-some years. And we all, in the support group, we all agreed that, unfortunately, that's generally not anything that's taught. In pulmonary rehab, they certainly talk a lot about it in terms of as it relates to exercise. But general daily living, breathing techniques are not talked about. And so I have my friend that has been doing this. She did a presentation for the entire group, and then she offered to do one-on-one. And I still have people that say that of all of the things that have helped them or their spouses, it has been learning how to breathe better and how to conserve their breathing. And so that was one of the best topics that we ever do. And every couple months we have her come back.
Great. You started to touch a little bit on sort of recruitment and engagement strategies. So I'd love to move our conversation there a little bit. And if you could give us just a little detail on how often your group meets and where you meet, and if you include caregivers in your support groups.
Okay, sure. We meet once a month at the American Lung Association office, and we meet at noon. And several years ago, we used to meet in the evening, and then we were worried about the participation really being reduced and as to why. So we polled a little bit of the membership, and determined that it seemed to be that, I think, a lot due to the age of the participants, noon worked best. And so we have it at the same time on the same day of the week each month. And in terms of recruitment, as I mentioned, that Loveless Respiratory Research maintains the mailing list. Although they send out everything, but we have the mailing list with the American Lung Association also. So that's one way, because when people contact the Loveless about clinical trials, then they always give them my information about the support group. The other way is that we have had presenters from both of the drug companies that provide the drugs specific to IPF, and they have been gracious enough to, once they find out more about the IPF support group, when they are visiting the pulmonologist and other physicians, they do tell them all about the support group, and they provide information as to when we meet and who to contact. I find that giving that information to the pulmonologist, although we always want them to have it, they really don't have time to be providing, generally speaking, to provide their patients with all this information. So talking to the nursing staff and it is also real valuable in terms of helping to spread the word about the support group. So we use that as a recruiting mechanism also. And the pulmonary rehab, in talking to, I've had the respiratory therapist and the directors of pulmonary rehab do a presentation, and then they take the information back also. So in addition to what you would think is the most likely place in terms of the physician's offices, there are other ways to seek out and provide information for the support group.
Right. I think this is a great time to hear and engage a little bit with the folks who've joined us on the phone today. So I'd like to start one of our very first discussion pods on recruitment strategies, and what are some good sources of referral. So you mentioned a few of those, but I'm wondering if the folks who have joined us on the phone today and are working or include pulmonary fibrosis patients in your Better Breather Club support group, if you have any thoughts or ideas to share with us about what are some good sources of referral. So there's a discussion pod in the lower right corner of your screen. If you want to type your answer in and hit the submit button or enter, we'll see and hear a little bit from our audience on other sources, good sources of referral. So Karen, I think I heard you say pulmonologist offices. Sarah is writing in pulmonary function labs. Any other sources of referral? Good sources of referral.
Respiratory therapist. That, again, they may be respiratory therapists that work as technicians with PFTs. That's also very good.
Great. We'll give folks just a few more seconds to type in their responses. I'm seeing pulmonary function labs, pulmonologists, pulmonary rehab participants, oxygen providers.
Yeah, I agree. I think oxygen providers. We've had our local DME company come and present on traveling with oxygen, and they also have, we've provided them the information on when we meet and everything, and they take that out to the patients also. So that's also an excellent source.
Great. All right, there's a little more typing going on. We'll give folks a few more seconds. Dr. Black, I'll put you on the spot here because I know you're kind of new to the pulmonary fibrosis support group, but any thoughts on sources of referral?
I have to say I've tried all of those that you guys have mentioned. Specifically, we have signs in our pulmonary function lab. I will agree, as a pulmonologist, I will agree that pulmonologists are not that good at reminding patients about support group. I've asked my colleagues multiple times. They always say, oh, right, yeah, I'll try. So I think targeting the office staff in some of my colleagues' office have been really helpful about reminding people.
That's great. That's a great suggestion. All right, we're seeing a few more business cards with meeting information to hand to folks you meet, assisted living facilities, hospice workers, and hospitals. All right. Thank you so much, everyone, for participating in that discussion. I want to move the conversation to more engagement strategies. So we'll launch our second discussion pod, and while you all are typing, I'll also ask Karen to respond to similar questions. So you started to mention a few of the topics, like teaching breathing, general daily living, and conserving breathing or conserving energy. What are some of the most requested topics from pulmonary fibrosis support group members, or maybe some of your most successful topics?
Yeah, I would say that what any treatment, not just drug therapies, but any treatment that is new. We have a pulmonologist from University of New Mexico that attends and takes one topic at a time and does a great presentation. For example, the last time she did a presentation, it was just on coughing, on what causes coughing and what to do about coughing. And so I think that's also very important. The other thing is we talk about lung transplants. And, as I mentioned earlier, that we have 2 people that have had lung transplants, but they tend to be the younger in the group, late 50s or mid-60s. And, there's so many things that other than just if they're eligible for a transplant, that we talk about just how expensive the potentially expensive it is, and the need to know what insurance pays for and where they live and what kind of requirements before they're even put on the list. All of those details are real helpful to the group that are even contemplating that they may be eligible at some time, for a lung transplant. So that's another important topic that we discuss, and they get the best information from those in the group that have had a transplant, because they're talking about the practical information, because they also acknowledge that, the people in the group can't tell them that if they're a candidate, that has to go through the physicians, and whether or not they go to Denver, to be evaluated, or to St. Joe's in Phoenix, then they know that somebody else has to make those clinical decisions, but we talk about the practical issues in the support group.
Great. And who are some of the speakers or experts that you might bring in to talk about some of these topics? I'm just trying to think of who Better Breather Club facilitators might be able to reach out to in their communities.
I would say that just as, it's great to have someone passionate like Dr. Black is, because they're more likely to feel that that it's important to reach people and to tell them about the disease. And so I think that if you have someone that's in research, whether or not, it's a research institute, as I mentioned about Lovelace, or a hospital that does research, to have the pulmonologists there that have a particular interest in it, it really does make a difference. I mean, other pulmonologists, they may be focused on, I'm sure, lots of different disease states, and that's where their love and passion is. But when you get somebody who really wants to talk about IPF and help reassure people and not give them false hope, but just reassure people that, things are being done to try to find out, not necessarily a cure, but how to improve their quality of life. And so, I think that would be some of the speakers. But the other ones, to get someone to talk about traveling with oxygen and respiratory therapist and the pulmonary rehab speakers that I've gotten, I think those are all valuable individuals, to have as speakers.
Great. And so The other question that I was curious about are some of the helpful resources that you recommend to pulmonary fibrosis members. Any literature, publication, websites, or actually services? Are there any services in the community that are helpful?
You know what? I'm not aware of particular services. I think any of the clinics that do research can provide some information about what may be available. Oxygen or financial support. I think those type of services would be of value to the individuals that are especially those that are newly diagnosed. But I noticed some, in looking at the discussion resources, somebody had mentioned about navigating the healthcare system, and I think that is very critical because in terms of what type of plan people are on, that they may not understand. They've been on the same plan, year after year, and maybe it served them well. But when they're newly diagnosed, especially if their physician is prescribing a new drug that may or may not be on, in clinical trials, and if it's not in a clinical trial, the health plan may or may not pay for it. So I think that is really important to find out what kind of problems that they are having, because everyone in my group, there's always something. They aren't hearing from the case manager, and sometimes they don't even know that there's a case manager available. So putting them in touch with a case manager within their health plan is also a great resource for them to use, and it just makes them feel better. Those are the people that can help them navigate the system.
Right. Wow. This has really been a very helpful conversation, and I see we have some submissions in our discussion pod. First of all, I'd like to mention our Lung Force Expos. These happen in communities across the country. The American Lung Association hosts these events, and there are definitely opportunities and ways to learn more about pulmonary fibrosis and to engage with patients and providers in the community. And there's some other really good mentions here, the pulmonary paper, Care for Social Workers, area on aging, and a pulmonary rehab specialist. So this is terrific. Thank you, everyone, for responding and submitting some questions.
And Pulmonary Fibrosis Foundation that Dr. Black had mentioned, that has a lot of information, a lot of excellent information on there.
Yes, definitely, definitely. All right. Well, this leads us to the Q&A portion of today's webinar. So we have a few questions in the queue, but if you would like to ask a question, you are welcome to enter your question into the Q&A pod. But we'll start, I think the first question is going to be for Dr. Black. Can you discuss how you work up a patient to determine if their pulmonary fibrosis is idiopathic or not?
Sure. So when a new patient comes to my clinic, they usually already have been diagnosed with pulmonary fibrosis, usually based on CAT scan. And so then to figure out if it's idiopathic or not usually involves a combination of taking a history, doing a physical exam, and sending blood tests. Those are honestly the most helpful things, and sometimes even considering a lung biopsy. And just to go through those things, history is really important, because if someone tells me, oh, I'm a parrot breeder and I have 500 parrots in my backyard, that will start me wondering if that might be hypersensitivity pneumonitis. If somebody says, I've noticed that my joints are really stiff and I'm having a harder time getting up in the morning, and I'm noticing that my fingers are starting to have some changes, that will make me start looking for other signs that might go along with something like rheumatoid arthritis. and I would ask more targeted questions about that. And then for a lot of the whole body diseases, there are blood tests that are very helpful in making that diagnosis. Again, things like rheumatoid arthritis, scleroderma. Something that we're seeing a lot more of is inflammatory myositis, which is inflammation of the muscles, but can actually affect the lungs even if people don't have muscle disease. And so we work closely with our rheumatologists, who are the doctors who really are the experts in some of these whole body autoimmune diseases, to see if a patient has other manifestation of those diseases in a way that might explain the pulmonary fibrosis. If we can't find anything in the history or on the blood test or on physical exam, and including, having been evaluated by our rheumatology colleagues, and if the CAT scan is in a classic pattern, that would make us think it's idiopathic. And that picture I showed before is really, as I said, a classic pattern with scarring mostly in the bottom of the lungs and not very much involvement of the top part of the lungs, and not a lot of other types of changes, so big nodules, big spots in the lung, or big areas that look really inflamed. So working closely with other physicians is important. I'm giving a long answer because this is really important to what we do, but technically, to make a diagnosis of idiopathic pulmonary fibrosis, we work in a multidisciplinary group. So we have our radiologists, our pathologists, if there's been a lung biopsy, and our clinicians all in the same room talking together to decide whether or not it's idiopathic pulmonary fibrosis or if it's something else, because, as I mentioned, it has really big implications for the treatment.
Great. Thank you so much. Okay, we have another question. As a facilitator, I've dedicated meetings for pulmonary fibrosis, lung transplant. This allows patients to interact, and lung transplant works for all the groups. COPDers have similar problems, and they can interact with each other and educate each other about the diseases as well. So there's a lot of common ground. So I guess it was more of a comment. But maybe just to wrap up the call, because I think many of our Better Breather Club support groups, have included patients with COPD. So I think the question of the day is, what should a Better Breather Club facilitator do? Is it okay to include pulmonary fibrosis patients and COPD patients, other chronic lung disease patients in the same group? And what are some of maybe the topics that would be beneficial to both? And I'll open that up to both presenters.
Sorry, Dr. Black, I noticed that there were a couple other questions on there also.
So I can start with those questions first, if you guys would like. So the question about lung reduction surgery, I would say probably not, because in COPD, the reason the lung reduction surgery is so helpful is because that big area of emphysematous lung is compressing, is kind of squishing the rest of the lung, and so the rest of the lung can't function properly because and it's usually the upper lobes are taking up so much space that if you can take that away, the rest of the lung functions pretty normally. Unfortunately, with pulmonary fibrosis, the bottom of the lung tends to be scarred up, and so if you try and cut it out, you still are left with less functioning lung. And so taking that piece of lung away probably wouldn't help much. And then I see a question about what's your estimate of the % of patients that are idiopathic. So again, it depends who you ask. David Lederer, the physician whose blog I mentioned, has made the point that if we look hard enough, or if we were smarter, probably none of it would be idiopathic, that if we could really understand the genetics and what are the environmental exposures that are important, we could probably come up with some sort of reason for all of these diseases. I will just say that the % that are idiopathic is getting smaller as we get better at doing, particularly I'm going to make a plug for some of these blood tests for the whole body diseases, because there are new tests available basically every year as the research continues. And so I think we're recognizing a lot more of those diseases. I also think that if we were better at picking up exposures, we'd probably realize that a lot more of this is related to the environment than we appreciate, but we just don't have good tests for it. So I can't really give a good answer because it just depends on the population and how extensive your testing is. Sorry.
That's okay. Well, I'd like to thank both of you so much for your presentations today. I want to remind our listeners today that we do have 2 additional webinars coming up in 2017. So please mark your calendars. And please make note of the new date, September 20th, for our next webinar. It was originally posted as September 21st, but it will be indeed be on September 20th, so please mark your calendars or update your calendars appropriately. I'd like to remind everyone that we do have a quick feedback survey at the end of this call. We'd love to get your feedback on today's webinar. I certainly learned a lot from our presenters today, so I hope it was a good experience for you too, but we'd love to know your thoughts. And lastly, again, I'd like to thank our sponsors, Boehringer Ingelheim and Genentech, for making this educational program possible for today. And I'd like to thank all of you for engaging with us in this learning opportunity. And this will conclude our webinar on meeting the needs of Better Breather Club members with pulmonary fibrosis. Thank you so much for your participation today.
Thank you.
So much.
This does conclude today's program. Thank you for your participation. You may disconnect at any time.